Welcome. My name is Mitchell Rosen, and I'm the director of the Rutgers School of Public Health Center for Public Health Workforce Development. Thank you for joining us in the first session of our 21st Signature Series. This series is an annual initiative that connects thought leaders from New Jersey, across the U.S. and the world with our schools community. The theme of this year's series is Public Health Workforce Development, and we will explore issues facing the workforce and how we can prepare, train, and educate an agile public health workforce that is prepared for the post-pandemic challenges and advances. It's my immense pleasure to introduce the first speaker of our series, New Jersey Department of Health's Commissioner Kaitlan Baston. Dr. Baston's career began as a full-spectrum family physician working with disproportionately impacted populations, with her expertise spanning Rwanda, the Dominican Republic, and Seattle, Washington. She came to Camden, New Jersey in 2015 and spearheaded innovative addiction medicine programs, including outpatient clinics, perinatal substance use services, and EMS addiction treatment. Prior to becoming the New Jersey Department of Health Commissioner, she built and led the Cooper Center for Healing, an integrated pain, addiction, and behavioral health center, and was an associate professor of medicine at the Cooper Medical School of Rowan University. As commissioner, Dr. Baston is focusing on decreasing health disparities, improving maternal child health outcomes, and enhancing integrated care for behavioral health and substance use disorders, ensuring all people have access to resources that can keep them healthy and access to compassionate, evidence-based medical care when needed. Throughout the webinar, you can ask a question. Use the Q&A icon at the bottom of the screen to ask your question, and we'll get to as many as possible after the commissioner's presentation. With that, I'm going to turn it over to Commissioner Baston.
Thanks so much, Dr. Rosen. And thanks to the Dean of Public Health who's here with us as well. Thanks, Dr. Kaitlan. It is such a pleasure to be part of this. And thank you for all of your work in the workforce development place of public health. Really, we cannot do what we do without a workforce. And I'm thrilled to be here and be able to talk about what it's like to lead the Department of Health. But of course, my leadership is one small piece of what we do in our 5,500 person department. It's the workforce that does this work. So huge thanks to the folks that make everything I'm about to talk about possible. In general, I think it's a really exciting time to be in this field. You are all entering, of course, after we've been in the spotlight from a global pandemic, and people think about infectious disease when they think public health. But it's so much broader than that. And it's a beautiful time to really enter the field when we're pausing and thinking about the lessons learned from the pandemic and how to incorporate that and resilience in our work and in our workforce. And it's also a time to really be thinking about what the community's needs are today and what we should be thinking about for the future. So I'll talk a little bit about all those things. I am, as my chief of staff likes to say, we're just regular people over here. I'm a physician. I have a background in treating patients, spent many years actually working as a physician. I'm dual boarded in family medicine and addiction medicine. And so I have a lot of experience with primary care. And then I ended up doing addiction and specializing in really perinatal or pregnant and parenting folks with substance use disorders. Because it was one of the populations that I just saw dramatically not getting the services that they needed within our health, basically the entire system of health and healthcare. And the longer I worked with populations in primary care that were underserved or underrepresented, the more I wanted to go upstream and really get at the root of those problems. And I used to say, I can't work in the system without working on the system, because for those who've been in the healthcare delivery system, it's broken and it's challenging. And we are all, the people who end up in working on the system and the people who are working in the system, we went into it for the reasons of wanting to help people and help people have healthy, satisfying lives. And I am so fortunate to now be the Commissioner of Health and actually be in a position where I'm thinking all the time about a larger picture of how to go upstream, how to help people stay healthy, I like to say that public health is, when it's doing everything it's supposed to be doing, people get to live their best lives and take most of it for granted. And I would love for our society to all have that option, to be leveling the playing field so that everybody can take their basic needs for granted and really thrive. So I'm going to talk a little bit about, as I said, about like where public health is going and my priorities that we talked about, and a little bit of what I think people need to build the workforce of the future. But to start, I'm going to show you an image that when I saw it actually when I visited the CDC. It was put together by the CDC. And since I saw this image, I have not been able to get it out of my head, because this is by the Injury Prevention Center in the CDC. And what they basically did was show, for preventable deaths of young people. So this is people from age 1 to 44 in our country. What are the primary causes of death? I think about this a lot in public health, because when we're thinking about prevention, we're thinking about public health, we're thinking about what is preventable in our youngest population, 1 to 44, right? What can we be doing better? And I'll show you what they did is they looked at this over time. So starting in 1983, this is what it looked like. And you can see what happens in public health over time. Back then, a lot of these injuries were actually actual injuries in car accidents, but drug poisoning is in here too. And if you saw HIV come on the scene before we had treatments, second highest cause of death, we got good treatments and it went all the way down here, right? It's still there. It's still in the background for us. You can see other things that we worry about still: stroke, diabetes, liver disease. These things are up and down. Infectious disease. You see certain things come on the scene in the early 2000s and you start seeing drug overdoses take off, right? All of a sudden, COVID-19 comes on scene. Did you see it pop way up and go down? And now here we are today, or 2 years ago, right? Near where we are today. Drug overdoses, suicide, and homicide. The top 3 causes of death in young people in our country, right after the peak of the pandemic, right? Before we got into an endemic state where we are now, COVID bounced way up there. And then this is what we're left with in the wake of COVID. I think about this because this image says so much for the public health workforce. Number one, things ebb and flow over time, right? There'll be times where a new disease comes on, like COVID. It comes on scene, we have to figure out how to manage it, and we need a proportional response to what that is doing to our population. And when we appropriately respond to that, we can pull it down here, right? Now it's no longer one of the top causes of death. It's still on the list, even in 2022, right? But lower. We saw it with HIV. It became a huge public health effort. People focusing on HIV because it became the second top cause of death and then went down here. And look at where we should be focusing today. If I think about what our proportional response should be, it really should be on substance use disorders. Here's where this unintentional injury deaths is kind of broken down so you can see poisoning is that dark color. Poisoning is, of course, unintentional poisoning, like things you would call the poison center for, and also overdoses. And that's where these poisoning deaths, you can see, take off, as we saw the fentanyl take off in our drug supply. Motor vehicle accidents were here, right? And they're still listed, but you saw as safety got better and vehicle safety, it has gone down. Everything else has decreased. We're doing better and better and better in public health response, but not in overdoses. We're not doing better yet, or we're just starting to. If you're watching some of the news stories come out about overdose deaths turning the tide. But when you dive in from my lens on the public health side, yes, overdose deaths overall are decreasing, but they're primarily decreasing only in the white population. They're still increasing in the Black and brown populations in our country and in our state. So when we think about the work we need to do as public health, and disparities being top of mind in our responses, as of course I'm working toward equity as my #1 goal, right? I want to get on this now and make sure that that's turning for everybody and that we're actually focusing on the areas with the highest disparities in overdose deaths. The other reason I think this is so important is we think about proportional responses, like I said, right? What should we be focusing on in public health? And I think about sometimes the things that hit the media or the things that scare people. Um, tick-borne illnesses or even mosquito-borne illnesses right now is a good example, because there are lots of parts of the world where mosquito-borne illnesses are driving a ton of health problems, right? Especially in countries just south of us. There was a huge dengue season this last year, and a lot of people that came to New Jersey traveling with traveling associated dengue put it on our radar. There are also other diseases that we worry about, like equine encephalitis, because it's severe. When you get it, it has a high mortality, right? Or other tick-borne diseases. But the reality is that when we look at some of these illnesses and what their impact is in deaths overall, it's very small compared to what we see here, right? And so, yes, we have to think about all these things, and departments of health are broad and vast. And I'm not saying we should not have a response. We absolutely need to have a response to decrease mosquito-borne illness and tick-borne and other vector-borne illnesses. And we need to be assessing that and keeping our population safe. So we can take it for granted that we're going to monitor those things. But proportionally, what we should be thinking about are the things that are driving the highest number of illness and deaths in our state, and what we can be doing here. For those who know my background in addiction, of course, I've focused on this, but there's a reason I focused on it, because I saw so many people dying young from this illness. And one of the things that we've done, just to share a little good news in the Department of Health, is that we actually, since my time here, went from having 7 harm reduction centers, which is an evidence-based public health approach to substance use disorder, to having 50 approved harm reduction centers across our state. We have harm reduction centers in 20 out of our 21 counties, and I can't wait to get that last county online. We've done a ton with the Murphy administration to decriminalize harm reduction supplies, and to increase access to just treatment overall. So good news to come, but more to say on that as we think about disparities in health. The bottom line with those top 3 causes of death nationally from age 1 to 44, being overdoses, homicide, and suicide, right, is that mental health is health. And you all know that, and I know that. But when you look at the statistics, it's just really nice to be able to say, hey, we have a really good reason to be focusing a lot of our energies on mental health right now in our country. We have a sadness problem. We have a connection problem. We have a crisis of our society not being sustainable. And we have a broadening income or wealth gap in our country. It's widening and widening. There are some beautiful kind of depictions of this that you can find these days to really help illuminate this problem. But the wider that income gap gets, the harder it's going to be for us to be working upstream and level that playing field. And so we have to think really creatively in our field. This is why integrated care is it's my number 1 priority since I've been at the Department of Health. It means not making people have to jump through hoops to navigate our system. It means wrapping our system around people. And that's really what we love to do in public health, is meet people where they are and go upstream. So I think about going upstream a lot because, we end up spending a lot of our time and effort in healthcare, which really in our country is sick care, right? Bailing out the boat. Somebody's really sick. Somebody ends up in a hospital. Somebody has devastating, end result of what their disease states are. That's a sick care system. That's a lot of our tertiary care in hospitals, which we desperately need. COVID showed us that, right? When people get sick, we need a very good, swift, and thorough response. But for every dollar we spend on public health or upstream, we save about $5.60 in total cost of care. So if we really want to bend the cost curve of healthcare, it is about efficiencies, and it is about making hospital care safer and better, and quality improvement, and really using it when we need it. But even more than that, it's about investing in public health, and it's about going as far upstream as we can for things like addressing the social drivers of health, which we know is 80% of actual health outcomes. right? So the more we do housing and the more we wrap around people and the more we give them their basic needs, again, level that playing field, the better their outcomes will be in the long run and the better our society will be because we'll be able to not have to spend so much of our incomes on sick care. So what do we need the future public healthers to do here with this thinking about spending upstream, invest on public health? Easier said than done, right? One of the reasons that's easier said than done is it's a little easy to tell the story, hey, I had an illness, all of a sudden I didn't feel well, I had belly pain, I was vomiting, I went to the hospital, it turns out it was my appendix. You did surgery, you took it out, I got better, you saved my life, right? That's an easy story to tell in a lot of ways. Sick care or taking care of somebody, especially when it comes to something that like a surgeon can do, right? Or an intervention can fix. That is tangible. That meets our immediate gratification need in our society. And that story is easy to tell. It's harder to tell the story of our work lets you live your regular life and take it for granted. You can drink water most of the time and be healthy in our country, right? We think about lead in water. We think about things like that because those things mean that they could disproportionately hit certain populations or have some people not be able to take that for granted when other people can. But it's our work that means you can take drinking water for granted, that you can walk down streets and generally be safe, that you can eat food and we say, hey, we're going to regulate how that is in our society, that hopefully you don't get as many mosquito-borne illnesses, and that when we really start focusing on the things that are causing young people to die, eventually you can say, hey, in our state, you're not likely to die of an overdose because we've flooded the state with reversals and medications and harm reduction. And actually, it's easier to access help for drugs than it is to access drugs. I'd love to get us to that point someday. But how do we keep telling the story of public health? How do we help say what we do every day so that the society can understand it better, especially in a time when real trust in our institutions have deteriorated quite a bit? And one of the things that I want to keep in the top of mind is not just, hey, how do we tell the story and how do we all talk about this together, but how do we really prepare for what the crises of public health are today and that are coming? Were we prepared for the pandemic? When we thought about it coming, we had flu plans, right? But when this illness hit us, we were wiping down our groceries because we weren't sure exactly how it transmitted. And we were terrified by the mortality rate of this illness and what it might turn out to be. And we should have been. And it had a disproportionate effect for a lot of communities. And so preparedness means thinking about not just the crises that, we see and kind of do in our day in, day out, but what could be coming our way. So let's think a little bit together for the next few minutes as we're thinking about preparing the public health workforce. What are those crises of today and tomorrow? Housing is one of those huge crises, right? With that income gap disparity and with the cost of housing going through the roof, housing is actually one of the hallmarks of being healthy, as we know from Housing First programs and everything we do there. And it is getting acutely worse in our society. So thinking about the fact that homelessness is growing and housing security is dropping, what can we do in a public health sphere to really be thinking about that? The federal government is thinking about that and included housing as one of the things we could address. States could address in their 1115 waivers, which allows us to spend Medicaid or classic health dollars on housing and housing supports. But we should keep thinking about how that impacts health and how we work with other agencies to do that. Food is health, right? That 80% being food, and not just us regulating food and what it looks like for people to eat healthy food, right? People might have seen that there was a listeria outbreak in lunch meats, and we were monitoring that very closely with the CDC, right? Some of that is monitoring health of food, but just access to food in general. The two largest food deserts in our state, the number one food desert is Camden City, number two, Atlantic City. And making the economic argument for grocery stores in those cities is really challenging. And unfortunately, businesses don't want to go in to run a full grocery store in those communities, keeping food deserts in place. That's devastating, right? And we have to do something about this in public health. One of the things we've done at the Department of Health is the Healthy Corner Store Initiative, in collaboration with the EDA, the Economic Development Authority, where we actually give grants to corner stores to help them put in refrigeration and actually give them contracts and help them build contracts to get healthy food in the corner stores, so that we're actually building healthy food availability right where people are and building local businesses in these communities. So we're actually keeping both the business, the economic drive, and the health all in the communities that need it the most. How about that homicide, right, is the third highest cause of death. Again, it goes back to me to our, poverty and our mental health crisis in our country. We know that crime is directly related to unemployment rates and poverty. I was listening to a podcast recently where somebody who so eloquently was interviewed about what it was like as he described them growing up in slums in East Africa. And what he said was, hey, when people grow up with very little and actually end up having nothing, they have big, angry, and violent responses to small things that happen to them. I think that's a universal truth that we need to pay a lot of attention to, which is that when we are deprived and we don't have our basic needs met, when we grow up in poverty, our brains actually have a trigger that happens to hopelessness, right? When we feel hopeless, when we have powerlessness, when humans have nothing and they're fighting for their basic needs, we know in neurobiology of addiction that it actually changes the way our genes are expressed in our dopamine receptors, which makes you more likely to develop an addiction if you have hopelessness. And we know that this also increases your risk of violence, that hopelessness, that powerlessness, right? And so it is our job to think about equity and to think about economic equity to actually help get us out of that crisis. Mental health is health. There's, of course, our growing environmental crisis and what that means to us when it comes to global warming, when it comes to just changes in our air quality. We saw forest fires, right? We think about what happens with the way that we're changing our environment and what industry does and cancer signals, right? We think about all this in public health a lot, but just climate change in general is changing what we need to do. Here's an example of what CDC has put together with climate change. So we have a new heat map index because we're heating up, and the days where people have heat that is really deeply affecting their health are increasing. And of course, we can't make it the same across our country. The heat is going to be different, and the heat index and heat warnings are going to be different in South Texas than they are in New Jersey. But we still have to note for our communities when there's a major change, and we need to make sure that we have evidence-based interventions for that, and we have to be ready for what happens with climate change. What about just in general equity across our society and outcomes, right? I said this is one of my biggest drivers and one of the things that I love to focus on. In New Jersey, we've had a huge focus on maternal and infant health outcomes and disparities in those outcomes. I'm very, very thankful to be working with the First Lady on some of these issues, and her vision for changing this in the state, and the amount of energy that this administration has put behind this is really unparalleled across our country. So I'm so thankful that we have the spotlight on it. But it can't just stop here, right? It has to be really embedded in all things public health. I talked about that with overdoses and overdose deaths, right? You can see it coming. You can see right now, still more white people in general are affected by overdose deaths. But as we've seen those decrease and Black and brown communities go up, I'm just waiting for that index, that moment where that shifts. And now all of a sudden, it's one of the biggest drivers of disparities in health. We can actually see this coming, and we can stop that train. If we bake equity and outcomes into everything we do when we look at our analyses, we actually can start making some of these interventions and changes and look at our outcomes in public health and make sure that we're actually driving equity in care and reducing disparities across the board. There's more than just race in that. What does it mean when we look at equity and outcomes? the single largest contributor to life expectancy is your zip code. It's where you're born, it's your environment, right? Or where you live. It's kind of a combination of where you're born and where you live. Here is our map in New Jersey and life expectancy. And in this map, actually dark is bad. So very consistently, Cumberland and Salem counties as a whole have the worst health outcomes in our entire state when it comes from life expectancy, when it comes to other, indicators that we look at, maternal and infant health. Those rural counties actually are also some of the poorest counties, and in general have very few resources for folks. When we think about that 80% of health is those social drivers of health. This is another way to look at inequities and where we need to be pouring resources into our society. So what's on the horizon, right? What are changing times pointing to for all of us to be prepared for? We talked about current state a little bit. What keeps me up at night now? Where are we headed? What storm is coming my way? When I first started in the Department of Health, really the long-term care industry was something that I knew I was going to have to think about and grapple with because it's been under a ton of strain. And I knew that the aging population is something that's really top of mind and growing, right? We know this statistically that the baby boomer generation will all be over 65 by 2030. It's 2024. I remember when 2030 felt like a long time away, and it just doesn't anymore. We have a growing aging population, and we currently have an unsustainable system to take care of our elderly. Our long-term care industry has been under a ton of strain in general, just from rising costs of healthcare, workforce strains in direct healthcare. We just don't have enough workforce in direct healthcare. And the industry is just really struggling to stay afloat. And it's not the best option, for a lot of people. Not everybody can age in place. A lot of people are sick or have very, very complex health issues, and they may need to stay somewhere with a lot more support. And there's an economy of scale in a community that can come from long-term care when it's done right. But we need to be doing everything we can to be actually helping people stay in place, age in place, and actually keep their intergenerational wealth, which also can be completely decimated from the cost of aging care and long-term care. So one of the hugest things on the horizon, and an acute issue I deal with every day. We know that social media and our technology is changing the way our brains work. We know that it's also, we've seen a huge increase in mental illness and suicide rates in teens. And there's a correlation, at least with social media and a lot of what we're seeing there. And we also know that there's a lot happening in the space of AI, and there's a lot happening already in information, in kind of what used to be the information age that's now turning into the disinformation age. And that's only going to make the trust in what information we can trust harder. So a lot to think about when it comes to mental health, and building trust in our society from that lens. And we're kind of trying to think all the time about lessons learned in the pandemic. And one of the things that I think about with this is we have certain things like stockpiling now of personal protective equipment and responses that would make us very prepared for the next potential infectious disease pandemic or infectious disease emergency. But is that stockpile really preparing us for whatever the next emergency is? For those who've been watching the news, we have a dock worker strike happening right now across the entire Eastern Seaboard that could disrupt supply chain to healthcare facilities, right? And acute needed resources to take care of people. So are we ready for that? Is our stockpile ready for that? We're crosswalking these things and thinking about this on a regular basis. Are we helping our workforce be resilient? That's one of the biggest lessons learned from the pandemic. It's not just PPE and infectious disease prevention and preparedness. It's, do we have the public health workforce that we need, which I know is what we're all here to talk about today. But how do we take care of ourselves? And of course, what kind of really bred a lot of mistrust during the pandemic was changing information and a lot of dis and misinformation, as I mentioned just a bit ago. How do we combat fake news in public health? How do we help people understand how to look at something for validity? and really think about research and science and what backs what we do every day and how important that is in the work behind our decisions. It's critical that we really invest in science, and we think about some of the amazing scientific medical advancements that we have. Cures for sickle cell disease. I mean, that is mind-blowing, right? This is science, and we know that it is critical, but how do we tell that story and help people see it in the day-to-day, in the regular communications? So, with all of that coming our way, and we're here to think about the workforce, it first means that we have to be able to tackle these problems without getting overwhelmed. I really thought about this a lot as a primary care physician because, day in and day out, I was treating somebody's diabetes or their high blood pressure or trying to help them stay healthy, and have a healthy diet and not develop diabetes when they were potentially on food stamps or food support, right? And living in a food desert. And how am I going to help them not get diabetes with that, right? Really, the problems we're trying to solve are poverty, systemic and institutional racism, intergenerational trauma, right? Those are the real problems we're trying to solve. And even I can get existential crisisy when I think that big and when I'm hungry. But in general, what we need to think about is we have done this and we can do this and we are doing this on a day-to-day basis. So we all have to make sure that we're taking care of ourselves and that we have to have moments to breathe and be in nature. For me, that means some self-care, right? It means being in nature. It means laughing with my kids. It means going on runs. Those are things that I know keep me sane on a day-to-day basis. But it also means building this into the everyday part of my job, which means making me believe that I can tackle these big problems one step at a time. It means working with a team of people that make me excited to show up and work every day. It means laughing at work. It means taking care of each other and thinking of each other as whole people. It means flexible work schedules. These are all the things we have to build into our day because there's no such thing as true balance. I will never spend enough time in the woods to make up for the number of hours we spend at work as a society. That's just the reality. I love being in the woods, but I also need to love being at my job, and we all do. So I'm going to spend the next couple slides just talking a little bit about how I take care of the Department of Health workforce and what we talk about on a regular basis, and what I would love all of you to talk about on a regular basis. This is what I'll wrap up with just for some good news and some messages just to take home with you. Number one is we all want a gold star at work, right? Part of the reason we get into public health and this work is that it makes us feel filled up when we do good things for others. We start with why. That's why we're going into public health, right? But one of the hardest things for people that are mission driven is separating your own personal value from your work product. So challenging. I am not my job. I am the commissioner of health. That is my role, but that is not who I am as a person. Who I am as a person is a creative person, a driven, a passionate person, somebody who loves working with other people and showing up every day with a human-centered work environment. Those are my attributes. I can make decisions quickly. I can involve other people in those decisions seamlessly. Those are leadership skills, right? But all of these things if I make a decision that isn't a great decision and something bad happens, I can learn from that. I can move on. That does not define who I am. If we can all learn that as people who are dedicated in this field, and we can show up every day and know that our value is not our work product, that will allow us to be free and actually learn together and grow and do this work in a resilient, long-standing way. It really combats burnout. The other is, I say to my team all the time, when the wind blows really strong in one direction, adjust your sails, right? We can't control the environment around us. We have to adjust our sails and blow with the wind and use that power. I think of obstacles and huge challenges as opportunities. When we have this longshoreman strike, I think, great, what an amazing opportunity to look at our stockpile. Are we stockpiling what we actually need to stockpile at the Department of Health? How do we think through these problems? How do we use this crisis? Never waste a good crisis. Use it and help it make us more prepared. that also helps me be resilient. I don't get, devastated by these things that I can't see coming. I use them and I make it the wind in my sails. And we also have to think all the time that we aren't going to solve poverty and racism in one big mountain, right? We're going to solve it one stone at a time. We're going to walk up this mountain. A wise colleague and mentor of mine once said, when you're overwhelmed by the mountain of work in front of you, it's time to stop and take a look at the view. Look how far you've climbed one step at a time. Just look out and look at the beautiful things you've done. So this is actually a picture of a mountain that's right outside my office door where I am right now, where every time we have a small accomplishment at the Department of Health, we write it on that mountain. And my colleagues write it on the mountain, and we take stock of the things that we have done so that we can actually celebrate our wins. Celebrating your small wins is so critical when you're trying to tackle big problems. And we're, of course, focusing on the community at hand. One of the biggest things that we have to do every day is keep the why in the center, which of course is why we got into this work, but make sure that it stays in the center and really empower the community. I'm going to share 3 small wins with you so that I can share kind of my mountain and things that we're focused on the community to leave us all with uplifting news and maybe some inspiration before I answer questions. One is we are empowering our community in New Jersey with their own information, health data that we hold at Health. The first thing we're doing is blood lead testing results. So we actually have childhood blood lead levels for the state, and we hold that data. But it's so important for that information to actually be in the hands of the community so that they can see patterns in their neighbors, so that they can talk to each other about it, so that they are empowered to do something about what's happening or what their results are and their kids' results are. So we are actually using an app where we actually currently have a lot of vaccination data. So you can see all your vaccinations in your hand if you need it, which makes life easier. And we're adding the other data we have one thing at a time, empowering the community and rebuilding that trust. We're connecting all of our health institutions through the HIN, the Health Information Network, so that hopefully people don't have to tell their history over and over and over again wherever they go in our health system. And we're making huge strides with this by having a master person index where we're actually validating information to the individual rather than trying to just cross-reference records. So this is critical and huge wins in our state. And one of my favorite wins this year was an over-the-counter order for contraception. So you no longer have to have a prescription to get birth control in the state of New Jersey. You can actually walk into any pharmacy that is participating, and there is a standing order for contraception there. Sorry, a standing order, not over the counter. So there's a standing order for a pharmacist for contraception. And so anybody can get access to that without having to see a doctor first. We are every day taking these lessons and building the future that we want to see for our community. And so I wanted to share these examples because they're things that I'm very proud of. And they're things that, make me believe that I'm moving one stone at a time here and that I actually can empower communities, work to build equity. We have healthy corner stores. We're democratizing data. We're democratizing access to contraception and empowering people to make decisions in their bodies when they want it. These are things we're doing every day that are slowly but surely leveling that playing field. And I could talk all day, every day about what we're doing in the addiction space and decreasing overdose deaths. Happy to answer questions about any of those things, but I wanted to give you all this kind of big picture because you will be building the future you want to see in public health, and all of the community partners that are on here working this every day. You are building the future that you want to live in. You're working to build what you think it should be, right? When I look at healthcare, I think, well, this isn't how it should work. So I'm going to build it the way I think it should work. And I want you all to be empowered to make those decisions and really make those changes. I tell people all the time, it's easy to see the problems. I see problems everywhere. Everybody sees problems everywhere. You could come to me and say, this doesn't work, that doesn't work, that doesn't work. And I'll say, yep, I'm aware, right? We all know the problems. I'm interested in solutions. And people who go into public health are here because we're solution focused. Bring me solutions all day, every day, and I will never get tired of hearing them. You all are the future. You can see some of the headwinds that are coming your way, and I trust that you will be able to adjust your sails. And I'm very excited to build a resilient workforce with all the flexibilities that we need to see in our future. So thank you for the time. Thank you for letting me present to you. And I will now hand it back to Dr. Rosen to take some questions.
Great. Thank you so much for your insightful presentation. We really appreciate the time you've given us today. We do have a lot of questions. I think the first one is, how do we build the workforce and recruit future students when public health is being demeaned and undermined in political circles?
Such a good question, right? We talked about that erosion of trust. And it is hard to think, hey, this is the field I want to go into today necessarily when other people aren't trusting it. And I truly, truly believe that it is the work that we do on the ground that builds that trust. I think a lot about the folks at the Department of Health in our community core and the people that during the pandemic, they used to say the people in the blue vests, because we would go out into the community and actually just have conversations with people, right? And that one-on-one conversation that we have can truly build trust. And we know this even in political information and data, right? People hold deeply held beliefs and fears, and media and social media and online forums actually can be a really hard way to combat that because it's the source of that. But individuals having conversations with each other really, really builds that trust back up. And breaks down some of those barriers. And we can all show up. Some of the ways we're building that is through that direct workforce into public health. So community health workers, doulas, EMTs, right? People who are starting in those fields. Some of those are direct care fields. Some of those are people who will track into public health fields. But there are areas where we're taking care and having conversations with people on the ground. And that is rebuilding our trust. We also need to think a lot about empowering people with their own information and doing those listening sessions. When I listen to people and they feel like we're not doing what they need, I have one truth that I always start with, which is validate what's valid, right? If they say the system isn't equitable, I say, yes, it is. I'm not here to defend a system that is broken. I'm here to fix it. And I need their advice and I need their experience from the ground. And it doesn't mean that every piece of advice I get is something we can incorporate, but it does mean we can listen with real ears and validate what's valid, and then move to solution focused and help them be solution focused as well. Because like I said, we can always identify problems. Brene Brown says, people who are standing on the outside and basically criticizing, those are the cheap seats, right? You're criticizing from the cheap seats. We in public health are in the arena. And I'm willing to be in this arena because being in the arena means that I get to make the changes that I want to see. And I think we're going to build the workforce that wants to do that too, because when you're sick and tired of the system, you work on it.
Great, thank you. So for many years, we've seen the workforce challenges of the local public health departments and all the workforce challenges that they're facing. And the de Beaumont Foundation Public Health Wins Report in 2023 showed between 2017 and 2021, 46% of state and local public health department employees left their organization. We see that senior staff are retiring, but of those employees who reported left, 77% had less than 5 years experience. So with the loss on both sides, we've got the senior staff leaving and retiring, and we've got the younger staff that are also leaving. How do we build up and sustain the public health workforce in New Jersey, understanding those statistics?
Yeah, thank you so much for sharing those statistics. I remember when I was first thinking about this position and looking at the number of people who were retirement eligible in the department, it was terrifying. It was almost 50% of our department at one point. And of course, like you said, we're having a hard time retaining young folks in the workplace. And it is, we see a lot with young people, and I love this about them, that they want to do the work and they're less loyal to the actual company they're working for and more to the mission or what they're working to do. And so many things we need to do on both sides. One, I'll just mention that we hired a workforce development director who is absolutely incredible at the Department of Health. So we have an entire office that is focused on workforce. A lot of what we're doing right now is thinking about well-being and wellness, like I talked about, leadership training, because we want to train leaders. And I want young, innovative thinkers to be leaders. You can be a leader before you're in a position of authority. And actually, sometimes being a leader when you're not in a position of authority is even stronger, right? We talk about leading from behind. When you demonstrate those leadership skills, it just opens that career path for you to go into other positions and make change if that's what you decide you want to do. So we're focused a lot on leadership training, on well-being, and then on doing what we can within the government structure for flexibility in work schedules, for making sure that we're meeting the needs of folks, and that we're not just focused on diversity, but we're focused on inclusion and belonging. So we're making like I said, I love showing up every day and having fun with my coworkers and having this breadth of experiences and where they come from and what they bring to the table. That's what makes my work environment rich. And that's what I want to see more and more and more of in the public health space. And I think those things will help us retain younger workers and help them feel like they have a place, feel like they belong, get excited to be working with their teams, and then also have those leadership options and the training and diversification of their skills. And of course, people are going to retire, and they should when they are ready to retire. But we are also working on building up our resilience and just our number two positions across the department by doing a lot of cross training and making sure that people actually have career pathing and folks behind them ready to take on some of their institutional knowledge. It's critical. And I said earlier, like, separate your identity from your work product. A lot of that is not hoarding information in order to hold your value at work. Your value is who you are as a person. And that work product can be collaborative, and you can bring other people into that fold.
Great, thank you. Given the ever increasing impacts of climate change, is there a role you see for local health departments in addressing the topic, either through education or something different, or maybe new partnerships? What are your thoughts on that?
Thank you, first of all, for bringing up local public health in that question. We desperately need an investment really across the board in public health, and local public health is such a critical pillar of public health. And we've seen some states do some really creative things in really tight partnerships with local public health and state health, because we need to be sharing data, sharing strategy, really thinking about what we do together. And local health can really focus on some key partnerships, as they do every day, with community-based organizations and what people are doing on their ground, and really have a pulse on their local needs and communities. I think the CDC has done a really nice job thinking about climate change and thinking about how we have, in that map, you saw different responses based on where you are geographically, right? And what the needs are of your community. And so, as an example, if when we had massive forest fires affecting air quality and coming across the state, certain communities in the north were affected more than some in the south, though many of us were affected. And as you think about rural areas, people may not be able to physically go long distances to a cooling center, right? How can we be using resources differently in some of those parts of the state? When we think about, just environment and climate change in general, what happens with our high agriculture areas versus other areas? Local public health is going to have such a great pulse on this. And we absolutely, as we think through lessons learned in the pandemic and how we codify funding and support with local public health and codify data sharing, climate change is just one great example of how we're going to have to do that.
Great, thanks. We really appreciate the connection and the work that our local health departments do. They're the boots on the ground for so much that happens in the state. So we're glad that that's a priority for the state. What innovative health communication means can help in the prevention of the list of the leading causes of death that you've listed? So the health communication.
Absolutely. I'm going to start with the top one, which is overdose deaths. So, critical to treatment of addiction is medication. It sounds wild that I have to say that out loud, because, when someone has diabetes or hypertension or, any of the other illnesses that are severe, right? Once you have full-blown diabetes, we treat it with medication. It does not mean we don't also do diet and education and exercise and environment, all those things for diabetes. But I don't say medication-assisted diabetes treatment, right? I just say diabetes treatment. And that is so critical for addiction because medications, when people are treated with them and stay on them, it reduces mortality by 70%. And I think there's still such a stigma, not just on addiction, but on the actual treatments for addiction. We don't hopefully stigmatize the treatments for hypertension. You know, we're not like, oh man, you're taking that metformin crutch for your diabetes, you know, you're taking that insulin crutch. We just say like, hey, does your doctor say you should be on this medicine? Like, help me help you take it, right? We have to make sure that the community is empowered to know what is likely to decrease their risk of death. We also have to talk a lot about, you know, engagement and harm reduction. And as I like to say, not a whiff of judgment in how we talk about it. It does not help when we say things are bad for people. I'll talk about smoking as an example. You know, if I say to you, hey, smoking's really bad for you, the people who smoke, they know that, right? People know that, and shaming doesn't actually shame people into getting better. What does help is empowerment, making people aware of resources that they could have if they want it, supporting them, talking to them like they're brilliant people who know what they need to know and clearly have reasons for what they're doing. Again, validate what's valid and then go into solution mode when they're ready to go into solution mode. Harm reduction is critical for this. And it works because it's not a whiff of judgment, because people can walk in and know that they're going to get the services they need. We need that same approach for mental health across the board, not a whiff of judgment, you know, and actual access in the moment, in the second that people need it. The way that we're building this, and I'll just share one quick thing about what we're doing from a public health lens with some of the opioid settlement funds, which is that we have a program that we're bringing to New Jersey, which was started in New York, called Matters. It's an app that actually, when somebody is using, can connect through this app to a medical appointment, a telehealth appointment, actual medications, a medication voucher if they don't have insurance, a transportation voucher if they don't have transportation to get that medication, and harm reduction resources in the moment they need it. So not, oh, great, I'll make some phone calls and put you on a wait list, but like, you need it right now, here you go. Here's a voucher, it's covered, here's how to get it, you can have it right in this moment. That's the kind of response that we need for critical things like mental health and addiction.
Thanks. Can you reflect on the challenges of working in a state with 564 municipalities? And what does that mean about the limits of the state's, the Department of Health's influence, and anything useful about that structure for public health?
Absolutely. I'm happy to talk about like local government and home rule and local public health, right? It is the combination of, we have 105, I think right now, health departments, used to be 104. We have many local health departments. We have 21 counties and, you know, over 104 health departments in our state. What that means is, you know, in practice to me, some of those health departments have a beautiful hyper local lens. It's the same with the municipalities, right? Some of them have a really great hyper local lens. They know what their people need. And just like when we listen to communities, that is invaluable. And we have to lean on those strengths, and we have to definitely have a partnership in those ways. What it also means is that we don't have exact equitable coverage of all the things that we need everywhere, because there isn't always a centralized system, whether that be the state, whether that be the county, right? That's making sure that everybody has exact access to the basic resources, and that people don't always know where to go for that. I'll give you emergency medical services as an example. You know, our EMS, our EMT system, if you call 911 and if you need ALS, which is like an absolute emergency, hospitals run that. But if you need just BLS or basic life support and you have to have somebody come and respond, that's local. That's often run at the local level, and it's kind of different all over the state. And I don't think the community always knows that. They don't necessarily know if it's a volunteer or a paid worker that's going to show up, if they're covered by their township or the one next to them, if they have kind of a coordinated county response or not. if someone's not going to come because they had volunteers and they don't actually have a paid workforce in their county or their township. So these are things that these are challenges that we want to look at from a state level, really to use our information to say, here are gaps. Let's work together to fill those gaps. And not to say we need a fully regionalized model, but we need partnership and we need collaboration and we need coordination. And our local public health leaders and partners are talking with us about that on a regular basis, because we all agree we don't want gaps and we want clear communication. And that was a very clear recommendation from lessons learned in the pandemic.
Great, thanks. We have about 5 minutes left, so we're going to get to as many questions as we can. We're probably not going to, well, not probably, we will not be able to get to all of them, but thank you for writing them in. We have a student in business data science asking about the use of technology to aid physicians and other healthcare providers to address healthcare issues or healthcare problems. What are some of the ways that you believe management and technology can help?
Yeah, so many ways, right? We have to get on the train of using technology to the best of its abilities, while also recognizing all of the pitfalls of technology, and we have to be aware. And this is critical for the public health workforce of the future. First of all, I talked a little bit about the Health Information Network and information sharing. This is a huge part of what technology can do for us in health and public health these days. We can share information without having to, retake people's histories over and over and over again. We can share critical information in real time. That is invaluable to people on the ground, and also to us as public health, workforce and workers, right? This sharing information is the future. We have an incredible statewide health information network. There's also a federal program, where we're trying to combine this on even a federal level. And we are going to build on this. We really don't have a choice. We must build on this and build the information that we're sharing to make public health and health easier and more streamlined on the ground. There's also, I think, I can't not talk about generative AI right now because it's so critical, right? AI in general has been used for a long time in healthcare. So we know we have artificial intelligence tools that help us identify things that are in some ways more reliable, or AI plus human is the most reliable than human alone. So for example, when we look at radiologic scans, or we look at radiology is one of the easiest examples. AI can be trained to find things that are really hard to find with your eye alone. And the combination of AI finding things and then the human being is this real or not real after that is amazing in radiology, and has actually made our diagnostic skills go way up. What's new is generative AI, right? Generative AI is we're training on, language processing and information, and being able to actually generate, and collate information. It is both incredible and terrifying in a misinformation age. I'll tell you a very, very brief story that was raised by a health executive at a conference recently, where he had one of his colleagues text him in the middle of the night saying, "Are you sure you really want me to do what just happened, what you told me to do on this meeting?" And he shot out of bed and called them and said, "We weren't just on a meeting." And they said, "We just had a Zoom meeting. I just had a whole 30-minute conversation with you and another executive." And it was a fully generated Zoom meeting. So it was a deep fake of a fully generated person with their voice and everything. And so that just gives you an example of, like, we already have trouble telling people what's real and not real. When we can generate things that are that feel that real, it's going to be very challenging to combat it. But we have to use AI to also help us meet the speed of the demand, and use, kind of go through information in a way that's actually valuable. I talk about electronic health records as being like the biggest junk drawers of all time, right? It's hard. You can never see the bottom of them. So we're going to need tools like this in a controlled environment with guardrails that help us do our jobs better in public health and in health. So it's time to learn. It's time to help the community learn with us. We cannot learn and outpace our community the way we often do. We have to have community empowerment as part of this, so that they feel part of this journey, and we don't like breed more mistrust as we use these tools.
Great. Thank you so much. We're going to stop the questions there. So thank you very much, Commissioner. I just want to put a note out there to save the date for our next session of the 21st Century Signature Series. It's November 14th with Brian Castrucci from the de Beaumont Foundation. If you are seeking CHES or MCHES or New Jersey Public Health credits for this, there'll be a link. There is a link in the chat box. Please do that to fill out your information, and you'll be able to get a certificate for and credits for this program. Thank you, Commissioner, for sharing your time and expertise today. We really appreciate it, and we look forward to more conversations and action on public health workforce development with you and your staff. So thank you, everybody, for attending. Have a good day.
Pleasure. Thank you all. Thanks for the work you do. Bye.